Hi,
Okay.
Shauna, just testing the English channel. If you can let me know if you can hear me okay. Okay, great, thank you.
Okay. Les participants aussi, il y en a qui, tu vois, je vois qu'il y a quelqu'un qui l'a déjà fait, mais qui n'est pas encore rentré, là, qui est dans la salle d'attente. Les participants, ils peuvent activer les sous-titres aussi. Mais ils ont les sous-titres dans la langue, non, en fait, dans les deux langues.
The participant can also activate the subtitles. Yes, but they have to choose which language they want them.
Donc, je vais commencer à laisser rentrer les gens tranquillement.
I'll let the people in.
Alors, je vais nous épingler.
Question, since I'm already recording, once we start into the real part of the webinar, do I have to start recording again? Or is
No,
it just gonna
no,
stay?
it's just going to continue.
Okay.
OK. Voilà. OK, donc je laisse rentrer les gens. I'm letting people in, OK? Bonjour à tous, on va se donner quelques minutes pour laisser rentrer les participants.
Hello, everybody. We'll just wait a few minutes so that we can welcome all the participants. We'll begin in a couple of minutes.
Alors, bonsoir à tous, merci d'être avec nous aujourd'hui.
So, good afternoon, good evening to everybody. Thank you for being here. We would like to begin by acknowledging that Spina Bifida, Hydrocephalus Canada, is located on Aboriginal territory which has never been ceded. We recognize the Kanien'kehá:ka Nation as custodians of the lands and waters on which we gather today. Tiohtià:ke, Montreal, is historically known as a gathering place for many First Nations, and today a diverse Indigenous population, as well as other people live here. It is in respect for the links with the past, the present, and future that we recognize the ongoing relationships between Aboriginal people and others in the Montreal community. A few words first about the webinar. There will be a question period at the end of the webinar So please use the Q&R button to enter your questions. The chat function is for reporting technical issues. This webinar is translated simultaneously. So the language is French. In order to listen to English, use the globe at the bottom of your screen, click on it and go to English. And finally, don't forget to return the survey you receive at the end of the webinar. This webinar is sponsored by our partner, Hollister Limited. We are delighted to have with us today Dr. Lisanne Campeau. Dr. Lisanne Campeau is Associate Professor of Surgery at McGill University, a urologist at the Jewish General Hospital in Montreal in the Department of Urology, and a researcher at the Lady Davis Institute. She completed her medical studies in 2005 and her surgical residency in urology at McGill University in 2010. And she became a fellow of the Royal College of Physicians and Surgeons of Canada. She obtained her PhD in physiology and pharmacology at Wake Forest University, Institute for Regenerative Medicine in North Carolina, and completed her clinical training at New York University in an accredited fellowship in women's pelvic medicine and reconstructive surgery. Her specialties are neurogenic bladder disorders, urinary incontinence, and pelvic reconstruction. She's deeply involved in the scientific community through her participation in organizations such as the International Society of Urology, International Continence Society, and Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction. She has published over 70 peer-reviewed articles and is an editorial member of several journals. Today, it's June 1st, and it's the first day of the National Month for awareness raising to Spina Bifida and Hydrocephalus. So, hello, I'm very happy to be with you this evening and for a very special day. So, I thank Spina Bifida Hydrocephalus Canada for inviting me. So, the purposes of the presentations are many. The objectives are, first of all, establishing therapeutic priorities in the initial management of patients with neurogenic bladder disease in the context of Spina Bifida, and mainly adult population. Second objective is to determine an approach to monitoring neurogenic bladder in order to avoid associated complications. And then, after the presentation, we'll be in position to describe non-surgical treatment modalities such as Botox injections. So, neurogenic bladder is very common among patients or persons who are born with Spina Bifida, or the other term that we use to define that is spinal dysraphism. So I won't elaborate all the details because I'm certain that there are experts who know much better than I do, but it's just to differentiate, to make the difference between the open one, like the myelomeningocele myelocele, so it's open, it's malformation at the spine level, at the spinal cord level, or it could be also another type of dystrophism, and there will be a deformation at the level of the vertebrae, and there won't be any exposition at the level of the skin. So it's what we call closed. So those are neural tube closure anomalies that affect the spine and spinal cord, and they develop during embryogenesis. We see that there are changes in the bladder very early during the fetal period when there is anomaly. And we can notice those changes as of the 3rd and 4th week of gestation. we see a prevalence that has reduced throughout the years through awareness raising, and especially the taking up of folic acid before and during a pregnancy. And we're talking about a prevalence of 0.74 to 0.83 per 1,000 births in Canada. So it's an average of 120 births per year in Canada. So I'll focus on the urologic aspect of this condition only. So those are variable. The clinical presentation is highly variable. So usually we talk about mosaic neurological deficit. So we see a lot of variability in that population. So it's important to individualize the approach with our patients. Then we know that with age, the growth, the increase in size. So because we're talking from birth until adult age, so we know that there will be an evolution of the condition with age. One of the first thing is it changes with the age, so the size. There are many changes at puberty. And then with aging, it affects all the organs of the body. So the person who have already a neurogenic condition, we see prostats for men or for women at the pelvic level. So it's a very dynamic condition that varies as the person ages. We can also see the secondary tethering that we see in 2 to 32% of the population. You see that there are many changes that we see at the bladder level. Structural changes caused by the nerve density, caused by spina bifida, a change in neural density, in nerve density. There can be a certain level of fibrosis, and I'll develop on that. But we also see some, some functional changes, of course, and I'll come back to that, and then molecular changes. So this image is not specific to spina bifida, but it's just to show you how the bladder, the neurogenic bladder, behaves in respect with the central nervous system. So when it is suprapontine, a lesion, we see usually an overactive bladder. So we'll have an hyperactivity at that level. When we're talking about spinal issues, so infrapontine and suprasacral, which is the majority of the issues with spina bifida. So most of the time, what we see is an hyperactivity of the bladder, and also an hyperactivity at the level of the sphincter. And we'll see different type of cases, and I'll develop on that later. But when the damage or the issue is at a sacral or infrasacral lesion, we can have a normal, almost normally active bladder or underactive. So we have a difference in situation depending on the dystrophism, whether it's open or closed. We see in the table that for open dystrophisms, they're affected more in terms of urologic activity. So we see that bladder hyperactivity is almost comparable, but the loss of compliance can have an impact on kidneys, and it's much more present in the open dystrophism. And the loss of sensation, same thing, more in the open. Then for sphincter dyssynergia, we'll see it more marked for open dystrophisms and less for closed dystrophisms. And then again, there's no differentiation depending on the level. So this is to show you to what extent there's a variability, a very important variability when we look at the neurogenic bladder in those populations. So many different cases. Then to determine if we will encounter complications, this is how we proceed. Those are a few criteria that can be indicators of complications. The first criteria is based on the urodynamic studies. So just to make it simpler, the UDS measures the bladder function, and it's done with a catheter that will measure the pressure in the bladder, and the catheter will measure the abdominal pressure as well. So we will fill out the bladder in a continuous way as we are measuring also the pressure generated by the bladder. Same thing with the abdomen. With a catheter in the rectum, this will allow us to measure the pressure and gives us a lot of information. One of the criterion that we will assess is the detrusor leak point pressure. So the level of incontinence at the detrusor level. And what we noticed is that the value where the pressure of the bladder will generate a leak in urine is the following. If we have a detrusor leak point pressure that is high, it's like it acts like a safety valve. It will be triggered only when we have a very high level of pressure. So a detrusor leak point pressure that is very high is telling us that the sphincter is very strong. So the bladder can generate very strong pressure before triggering the valve and reducing the pressure. So when we have a detrusor leak point pressure that is very high, we talk about hostile bladder. Traditionally, according to the study published in the 80s, the studies carried out around on 12 children, they established that the 40 centimeters was the break-even point, but even lower pressures are also an indicator of future complications, and I will list them later. So the number one that we really want to avoid is kidney dysfunction. Another criterion that we look at is compliance. To what extent bladder can extend when it's filled. So a high level of compliance is a good sign, means that the bladder can accommodate a high volume before generating pressure. So over 20 milliliter per centimeter, it's normal, so no dangerous pressure. So this is another criterion that we use to measure the risk with the bladder.
The synergy is the contraction. We can only establish this with urinary that is voluntary, frequent. If not, they empty it only with the catheter. Other indicator of complication here is bladder overactivity. If there is bladder overactivity, can cause involuntary contractions that are frequent, high pressure, and that can cause complications in the future, but the literature is still a bit ambivalent on the subject. In the image, you see reflux, vesicoureteral reflux, and the issue here is if it's not detected and we do a urodynamic assessment, that will decrease the pressure and the volume will go to the kidneys and decrease the pressures that we on the aerodynamic assessment. But the issue here is that pressure, if it's not detected, can go back to the kidneys and can cause repeated infections. So this is the worst possible combination. Another indication would be the shape of the bladder with trabeculations. This indicator tells us that there is a high risk for the bladder. So when I meet a patient with a neurogenic bladder, whether they have spina bifida or other neurological issues, there are different priorities of treatment. First is the preservation of renal function. Number one, especially with the spina bifida population, we know that about a quarter of them, because they have it since a young age, they will develop renal kidney failure. So it is our main priority to keep their kidneys healthy for as long as possible. The second priority is continence for quality of life, so sociability, on so many aspects of life. So urinary and fecal continence has a high importance, so we have to prioritize it. Then we want to reduce the risk of infection, as that we see often on the population that has a neurogenic bladder. There are a lot of expenses with our healthcare system in these issues. Of course, we want to avoid bladder cancer with this population that has a slightly higher risk of developing it. It's low, but if they develop with their population, it's usually more aggressive. We want to make sure there is independent care for children, teens, or adults. We always want to try to keep this in a priority. And finally, the sexual function and the infertility aspect that this population can experience. So we want to address this during all our care protocols. So for adults, I'm a urologist for adults. I don't see these patients when they are children. I cannot speak to the pediatric care of these patients. I see them in a transitional clinic. So as soon as they're 18, unfortunately, they're not followed by the pediatric hospital. So there's a transition. They have already been treated for many years, and they transition to other healthcare professionals. So what I see initially as when I meet them, first of all, I want to determine the current function of their anatomy, which surgeries they've had. I want to better understand their anatomy, the opening get closed, have they gotten an enterocystoplasty? So all this information is important. So I have to look at their pediatric information file. So if they have not been seen for up to 3 years, for example, things can have changed. So I want to know what their current urinary status is. So I want to also define the goals and what they want to address, first of all. I want to also evaluate, assess the support that they get on different levels. Social, for example, are their parents still with them? Do they still go to school? I want to get all that information. And I also want to see how that impacts the care I can provide for them. We also want to assess the recent or past urological symptoms and determine sometimes if there's a specific reason why they are presenting. the majority of symptoms in adults with spina bifida, first of all, is incontinence, present with 50% of the population. Then recurrent urinary tract infection with a third of the population. Then on some patients, there is some difficulties with catheters, so I always talk about this. And less frequent, we have lithiasis. At the high point of the urinary apparel. So at the adult age, this population of spina bifida are more at risk to develop conditions such as obesity. If they have mobility issues, they can also experience higher sexual dysfunction than the general population. And because of their medical condition, they are more at risk to develop problems of depression. There's reduced mobility, as we said, and this can have a lot of consequence on different aspects of their life. And at the adult age, they can lose a lot of supports, whether they be social or by the parents, caregivers. And if they are no longer in the school system, they lose a part of the social support that can affect their care. So what I do first with the initial clinical assessment, I do the medical evaluation of the history. I want to know what type of spina bifida they have, if they are ambulatory caregivers they've had in the past, if they have a shunt, if they have allergies, what surgeries they've had. I do a complete physical examination. I evaluate their abdomen. Of course, a neurological focused exam, a urinalysis, depending on their presentation. If they urinate on their own, I evaluate the post-micturition residual and see if there are issues that have not been identified. In general, there's two courses here. So there is a CUA. First, that was written in North America of the Canadian Neurological Association, written in 2019. And I'll talk about that over the next few slides. And in 2021, the American Neurological Association has written a course of action to follow. So we can offer a voiding calendar to understand the volume and when they catheterize. If there is incontinence, a pad test is useful, and non-invasive flowmetry can be useful as well. If they we don't know in what category of risk they are, it's important to determine their renal function or have recent renal imaging, because that can reveal possible complication. And if we don't have them, we will ask for a urodynamic assessment. This table is the guidelines of the Canadian Urological Association. So there's a very exhaustive list of all the aspects we have to analyze. Sometimes we can't analyze all at the first appointment. We do follow-ups and find out more. I prioritize the neurologic aspect to prioritize the renal function, and then we'll go on other levels like the sexual functions, for example, during the follow-up. So we want to have a proactive monitoring approach, whether it's pediatric level or adult, but at the adult age, we will check to prevent complications. So we won't only be reactive, we will be proactive. We won't just react to a complication, we want to prevent them by using this stratification according to the risk of category. So we will do analysis of post-urinary conditions. So the population with Spina Bifida is usually in the high or moderate risk, depending on the condition of their Spina Bifida. Same thing for SCI, MS. So they will have a baseline UDS, a renal, US and renal function exam. So, and what we find after with these exams can determine if they have other risk factors that will put them either in high risk or moderate risk section or categories. So the objective here is if they are in the high risk category, we want to treat them to send them to the moderate risk section to prevent possible complications. So this proactive surveillance approach, if we look at the population with a neurogenic bladder population, we look at who uses a bladder drainage, either with Crédit's maneuver emptying, or by reflex, or by using a Valsalva. So these are suboptimal emptying that are in this category. If in the BUD we see sphincter dysarthria, hyperactivity, a loss, a reflux, or dangerous destruction, they will be in the high risk category. If we notice a temporary deterioration in the imaging, they will have in the high category. So which patients are in the intermediate risk category? Those who empty with indwelling category or spontaneous or have spontaneous urination in an acceptable way, or have a bladder drainage. So BUD patients who possibly had previous risk but do not have one anymore, and who have stable imaging and or renal function. So it will differ whether the surveillance will differ whether they are in the high or moderate risk. We always suggest an annual evaluation to make sure there's compliance to the treatment. We also will suggest a yearly renal imaging function. In general, this is the best modality to check, to determine if there has been a change with their renal anatomy.
So in that case, we suggest UDS every 2 to 5 years, or if there are complications, so in that case, that would fall into the high risk category, then it would ask for a more frequent UDS. For patients with higher risk, according to the criteria that I mentioned, an annual UDS is recommended. Some persons recommend a cystoscopy every 2 years after 10 years of risk increased. So for some patients, should we do a cystoscopy every 2 years? There's no consensus because it's a little bit harder to determine. And of course, it's an investigation that is also more invasive. So what are the complications to avoid? First complication is the deterioration of renal function or the development of renal scarring. How do we see that? With the renal echography, in order to better understand the anatomy if there are, if there's an atrophy. The DMSA, that is a nuclear imagery, allows us to better assess the renal scarring. But then the creatinine is not the best test because of the reduced mobility of muscular mass. It's not really representative. Sometimes it can be underestimated. Normal creatinine is a person who can move, but with a person with spina bifida, the same level of creatinine could suggest dysfunction, a renal dysfunction. So some persons recommend to assess it with cystatin C. That is more reliable. We want to avoid urinary lithiasis. We know that the risk with spina bifida population, the risk is higher, 33 times higher. So it's not neglectable. So patients who are more at risk to develop bladder stones, those who have enterocytoplastic catheter infections. And we know, according to the literature, and you see it in the table, we know that the patient who have a spinal issue and who had to undergo surgeries are more at risk. We see that the risk increased from 1 to 3 compared to the general population. The urinary tract infections are also a complication that we try to avoid. It's still very prevalent. It causes 22 hospitalization out of 1,000. And we also see rates of bladder neoplasia from 1.2 to 4.5% after enterocytoplasty. So what are the non-surgical treatments? I want to focus on this aspect because I know that there was already a webinar on that theme. So what are the non-surgical treatments that we can adopt? First thing, we want to figure out what is the best draining system, so voiding system for them. So intermittent catheterization is the best option, but then depending on how serious is the issue, part of that population will need avoiding through intermittent catheterization or other means. Usually that's the one that we prefer because it presents less risks in terms of infection, less anatomical issues, less erosion at the level of the kidney, and less blood, less chances to cause cancer. So it presents a lot of advantages. Intermittent catheterization is certainly more convenient compared to other type of like indwelling catheter. Now, sometimes even it reduces the dependence on the helpers. In that case, in that first case, the second option is another type of catheterism. Urethral catheter can cause a complete erosion of the ureter. So in that case, it creates a total incontinence. And for a man, it can also cause long-term issues in terms of infertility and sexuality. So if it's not possible, urethral catheter is the last option. In terms of pharmacotherapy, in general, the majority of patients who have a catheter, for them, we suggest a pharmacotherapy with anticholinergic. The purpose is to keep the bladder as compliant as possible. And we know that if they have draining system, if they have a hyperactive bladder, the pressure is higher. So it's possible to relax the bladder with beta-3 receptor agonist, or even proceed with the detrusor injection of Botox. So according to a study, over 1,370 adults with spina bifida, with an average of 26.1 year, CIC was used for 58.4% of patients. There are few complications with intermittent catheterization, 3.5 per 1,000 patients per year. And it's important to check their compliance. I usually ask them if they have any issues with catheter, what is the size that they're using, can they proceed as many times as they wish, because we know that there's a large proportion, 20 to 40% of patients will switch to another type of system. So the purpose is really to preserve the renal function, and we know that we can preserve kidney function, reduce scarring, and less infection. So what are the pharmacotherapies? On one hand, we have the anticholinergics, oxybutynin, solifenacin, and trospium. So those are the three main ones. And we know that those molecules can improve the hyperactivity at the bladder level. So we'll reduce its hyperactivity. It will increase the compliance and increase the initial capacity. Some studies also suggest that it will help the bladder remodeling, globally speaking. But then it's important to balance the intake of the medication with the possible side effects. We don't know exactly why, but most of the time, the molecules are better tolerated, less secondary effect, less side effect, like constipation or dryness at the mouth level. But that's an aspect that I always assess. I always ask how it goes with the constipation, and it's important to do a follow-up on that. And also, some literature suggests that there's a deterioration at the cognitive level. The literature is very ambivalent. There's no consensus on that. But when we realize that this population has been treated since a very young age, and they will have to take those medications for their whole life, we have to keep that in mind. That potentially there's a risk of cognitive deterioration on the long term. The other molecule is the beta-3 receptor agonist, and the only one that we have in that category is mirabegron. We use it since 2013, and it's less studied, however, on neurogenic population. But we see that there's a certain level of improvement in the frequency of mention, and it seems to improve not only the incontinence, but also the compliance and the capacity and pressure. For some patients, we can also envisage the combination of the two in order to optimize the efficiency. Now, I'll focus on Botox, botulinum toxin. So we have type A, and it is used through injections. So this neurotoxin derived from anaerobic bacterium Clostridium botulinum is functioning this way when the neurotransmitters get out of the cell, basically. So there's a synapse that is allowed by this complex that is called the snare proteins. So this is what we would like to see for the release of neurotransmitters. With Botox, once we inject Botox, it is kept in the cell, it is absorbed in the cell, and this will break basically one of the components of the snare proteins. So the toxin of type A will act at the level of SNAP25, but other toxins will interact with other proteins. So as we're breaking this complex of proteins here, then at that moment, the neurotransmitter cannot be released. So it will prevent the release of acetylcholine in the muscle. And there are some studies that show that it can also have an impact at the substance P level. So it can act also at the level of the nerves, afferent nerves. So it can modify the sensation, not only the muscular tension, but also the sensation at the same level. So with the injection, usually with the neurogenic population, we're using 200 units. Why? Because this is the quantity that was studied the most. Some studies focus on the 300 units, but there weren't outcomes sufficient to turn to that solution. So we know that if we increase the number of units, it may develop in the patient a higher level of tolerance. So the optimal level for getting a certain efficiency is 200 units. And we want to use it 24 hours after reconstitution. We do that. Usually, it's a treatment that has to be repeated every 8 months as an average. So the efficiency of that chemical denervation lasts an average of 8 months. And it can take up to 2 weeks before taking effect. So you see, with a cystoscope, you will feel, well, that's a local anesthesia. And then you use a needle and you inject 20 injections of 1 cc according to a pattern, a specific pattern. In some population, well, there are some complications that the patients may have. There's a risk of urinary tract infection, 15%, bladder pain as well, alguria, hematuria, or bacteria also. Now, we also have a urinary retention risk that is variable. So those patients might need also a catheter. For patients who do not use usually a catheter, I would use 100 units, while for patients with catheter, we would use 200 units doses. And another risk is also, after the use of Botox, is the generalized weakness. It's not a very high level of risk, but it might be very debilitating.
So what are the contraindications? So active UTIs is a contraindication because injection in an inflammatory ISIS can propagate elsewhere in the body. If there's urinary retention, a difficulty initiating CIC, and hypersensitivity to Botox type A, and we want to avoid a dose of 360 and over 3 months. So if they receive the injections for other conditions, we have to avoid it. So we usually do a urine culture. We don't do it if there is a cystitis with a gel to do it. We do it with a needle. We fill the bladder We filter from 2 to 4 millimeter, and there's no difference if we inject trigon or not. The results that we see in dystrophism of less than 18-year-olds. So we in systemic review of literature, we see less continence issues. The P dot max reduced, also a very good results, better compliance as well with the adult population. So that was for children. For adults, 74% have an incontinence resolution, heightened capacity in system with the cystometric of 86.6 milliliter. Muscle weakness, however, was developed with 3 patients. So what happens after an enterocystoplasty? There's a high clinical efficiency with 58% of the efficacy and a max reduction of 43%. And the cystometric capacity can be increased by 333 to 426 milliliter. So concluding rapidly, because I went over time, it can help a very heterogeneous population. So when we are surveilling, we want to favor a proactive approach to avoid complication. We check according to risk stratification. We do an annual evaluation and imagery, so a scan of the bladder. So every year with high risk population, 2 to 5 years for intermediate risk. And with people who don't have a frequent emptying, we work with CIC. If there's an issue with pharmacotherapy, we suggest a Botox injection. Of course, there's also the anticholinergic and the Bragon approach. So thank you for listening about my experience in all these sectors. So thank you, Dr. Campo. That was very thorough, very technical, very informative. In French, I did not receive questions, so I will give the microphone to Shauna.
Thank you. We do have a couple of questions. One is, why do people with spina bifida have frequent pyelonephritis? And I'm already on prophylactics and still get 8 to 10 infections a year.
Role. With patients who self-catheterize, we want to avoid prophylactic antibiotics. It does not work with patients who self-catheterize. However, there are other ways to decrease the likelihood of recurrent infections. Some patients with some of the literature has shown that using gentamicin intravesically for patients who self-catheterize can decrease the likelihood the likelihood of recurrent urinary tract infections, but recurrent pyelo are particularly problematic.
Sorry, put myself on mute again. Thank you very much. That was very thorough answer for that question. Did you have a question, Laurence?
You're muted.
Non, toujours, j'ai pas de question en français, so go on. There's a
Okay.
few other ones.
Okay. The other question I had was, I have an ilia conduit, but my bladder was not removed, and now it is so dried up that you cannot get a catheter into it. Do most people have to have bladders removed at some point? I've had the conduit for 50 years.
So there's no real consensus again when patients who undergo an ileal conduit, whether or not a simple cystectomy should be done at the same time. This was not part necessarily of the scope of this webinar, but the concerns with having a bladder, persistent bladder, is that it's basically it's a vessel that can become contaminated with bacteria, and there is a risk of developing an abscess or pilocystis, basically the infection within a non-functional bladder. But oftentimes the bladder in these patients becomes quite hypertrophied and contracted, and really does not accommodate much urine, cannot necessarily become infected. And so there's quite a lot of variability. And now if the patient has had an ileal conduit and has not developed infection in his native bladder, there's really no reason to address the native bladder, because it's not causing any problems. If it is causing problems with recurrent infections or abscess forming, then yes, it might need to be addressed.
Okay, I see one more question here. We have a 10-year-old son. I know that you're an adult urologist, so I'm not sure if you'll be able to answer this question. Who has a neurogenic bladder. He currently uses a size 10 French catheter. It has been quite some time since the flow of urine is slower, especially in the early morning. What could be the cause, and is there anything to make the flow stronger?
So I'm always cautious during these webinars when patients are asking very specific questions to their case. I cannot really provide any medical advice or suggestions. Just generally speaking, when you look at patients who self-catheterize and they use a catheter and they look at how the urine comes out of the catheter, the flow of urine that comes out of the catheter does not indicate anything, is not problematic, whether the flow is slow coming out of the catheter, the flow is fast. It's not indicative of anything. The flow will be dependent on the size of the catheter, but as long as the bladder empties is what we want, generally speaking, again, not specific to your case.
Thanks very much for that. And I had a question for you. Comes up quite a bit in our support group meeting. And we talk about catheterization issues. And I'm wondering if you see any incidence rates in women who have catheterized for a very long time and who develop prolapses.
That's an interesting question. So the catheterization, the self-intermittent catheterization in women does not lead to prolapse. Now, there's no cause and effect between self-intermittent catheterization and prolapse. However, pelvic organ prolapse is usually a multifactorial condition. It's caused by the lack of or poor tonicity of the pelvic floor. And pregnancies, deliveries are generally the most common risk factors, as with aging, as with changes with menopause. And so all of this can lead to changes in your pelvic floor support. In addition to that, in patients who have a neurological condition, while their pelvic floor is impacted by their neurological condition, and the tonicity of their pelvic floor is also impacted, and that change over time with aging can lead to pelvic organ prolapse. But it's not necessarily the catheterization that led to pelvic organ prolapse. So what can happen in the present, if a woman has pelvic organ prolapse, it can make self-intermittent catheterization more challenging either finding the urethra or emptying the bladder if there is a significant prolapse of either the bladder or the uterus that can lead to a bit more challenging catheterization.
Great, thank you for answering that. I think we're all done with the questions.
Donc, ça va être un clap de fin pour ce soir. Merci beaucoup, Dr. Campos. Si jamais, et ça arrive assez
If ever, and it does happen often, we receive other questions by email. People need to think about things. Can we send them to you by email? Yes, of course. So no rush to answer them, but if we can do it, that will respond to people's expectations of these webinars. So thanks again. In 2 weeks, there will be a webinar on pediatrics. So thank you. Thank you. Have a good evening.